Manisram Krishna, both are well-known cardiologists. And today's convener, Dr. Kritika, and mentor, Dr. Nandini Kupasamy. So I welcome on behalf of IAP TNSC. And I really thankful to our academic coordinator, Dr. Tirumurugan, is and the president-elect of 2026 also. And our Rajkumar Treasurer and Secretary, Dr. Narmada, and Gopal Subramanian, Vice President, and our President 2024, Dr. Balashankar, and Somasundaram, President-elect. Really thankful to each and every one of you. I think maybe it's last PG teaching program, my tenure this year. And I hope this will also continue the same thing for next year also. And really thank and each and every one of you to make this possible. Really thankful to our Dr. Singarvel sir for his guidance. And really thankful to my brother, Dr. Tirumurugan, who has helped us make this academic program very successful one. And thank you one and all. Thank you very much. Thank you.
Thank you, sir. Now I request our President-elect and the scientific advisor of IAP TNSC, Professor Dr. Singaravelu sir, to say a few words.
Thank you, Thiru. Our most respected and dynamic President, Dr. Rajendran, and our Treasurer, Dr. Rajkumar, convener of this program, who is doing extremely well, Dr. Kritika, who was committed and doing very well all the PG teaching program, ably supported by our academic coordinator and our President-elect 2026 of Tamil Nadu State, Dr. Tirumurugan. And it is a very happy moment that today this cardiology topic, second time we are doing this year, and the most respected and dynamic and both academician and active IAPN, whom I enjoyed their hospitality as a guest of honor in Delhi. Very recently came to know much about her through my son, Dr. Maniram Krishna, who is also today as a faculty. Dr. Smita Mishra ma'am, welcome madam. We are the person you immediately accepted an invitation within a short notice. Sorry, we could not provide you everything in time, but you are so courteous in spite of that being a faculty in a conference at Bhopal. Thank you for sparing your time. I'm surely that it will be very enriching to our postgraduates who will join a large number in YouTube. And Dr. Maniram Krishna, my beloved son, I'm happy that he is doing extremely well wherever I go. And Madam Smita was telling, sir, I didn't know that Maniram is your son. He is doing very well. We know him. That is, as a proud father, I'm very happy about my son that he has also accepted in a short notice. With this, all the today's postgraduate presenters of Madurai Medical College, definitely they will learn a lot from these two faculties and all the other our academician who has joined in the platform and others in YouTube. With this, I thank our president for giving me this wonderful opportunity as a scientific convener for this year, which helped me a lot when while traveling and everywhere our academic things were very well appreciated. Even now Smita ma'am told that we have to get academic grants for people to travel to Tamil Nadu. That extent our Tamil Nadu is very popular in academic and other things. So in this I thank each and every one of you as academic coordinator helped me to get elected as a president elect. So with this, I thank and wish you all the best. I'm sure that our incoming president Somasundra will take over this project and it will continue very well in future also. With this, I thank and my personal thanks to Dr. Kritika, who has done extremely well. And every time she used to call me and repeatedly see that the program goes flawless. With this, I hand over to Thiru for giving me this opportunity. Thank you all.
Thank you, sir. Thank you very much, sir. I think without wasting much time, I will now hand over the proceedings to Dr. Kritika, who is the coordinator for this program, to start the proceedings. Over to Dr. Kritika.
Thank you, sir. Respected President Rajendran sir, past President Balashankar sir, and President-elect Somasundaram sir, respected National President-elect and Academic Advisor, Scientific Advisor, Dr. Professor Singaravelu sir, dear Narmada ma'am, Gopal sir, Rajkumar sir, and Thiru sir, the Academic Coordinator of this year and President-elect. Thank you so much. Good evening. And it is really an overwhelming moment for me because this is the final program of this year of IAP PG Masterclass. It is a delight that the topic is every postgraduate's favorite, cardiology. And Dr. Smita ma'am, who is the HOD of Department of Pediatric Cardiology from Manipal Hospitals, Delhi. She will be the leading faculty. And the second faculty for us will be none other than Dr. Maniram Krishna, who is a senior consultant pediatric cardiologist from Tiny Hearts Children's Hospital, Tanjavur. Thank you so much, ma'am, and thank you so much, sir, for accepting our invite. And it's a double delight because the students are from the Alumni Institute of mine, alma mater of mine, being mentored by Professor Dr. Nandini Kupasamy ma'am, who is the director of ICH and RC Madurai. And the presenters today will be Dr. Priya and Niranjana. So without wasting much time, I request Priya to share her screen and start presenting the case. Thank you, everyone. Priya?
Over to both the faculties, Smita ma'am and Maniram. The stage is yours.
Ma'am, sir, you can intervene any time and ask questions.
Okay, sure.
Thank you, ma'am. Priya?
Good evening, sir.
Yes, ma. Yes, ma. You are audible, ma.
Shall we continue, ma'am?
Yes, ma. Yes, ma. Yes, ma. Please proceed.
Second order by birth, born out of Sangana's marriage.
Priya, your slides are not moving, da. Priya? Priya, your slides are...
Ma'am?
Yes,
They're
it's
not
moving
very
now.
well audible. In fact, there's
Yes, you can
noise.
come closer. You can come closer to the mic. You can place yourself in a place where your network is good. Priya? Priya, Niranjana? Yeah, your slides are
Yes,
moving, but your voice is
audible
breaking,
now,
ma.
ma'am?
Your voice is breaking, da. You can come closer to the mic and speak.
Okay, ma'am.
You're having only one device, no? Should not
Yes,
have
ma'am.
two
ma'am.
devices.
You start,
Ma'am,
Priya.
is it audible now, ma'am?
Your voice is breaking,
Is it
da. Your
audible
voice is
now,
breaking.
ma'am?
Yeah, you're audible, but your voice is breaking.
You switch off your video.
Yeah, that will help.
Okay. Is it audible now, ma'am?
Yes, ma. Yes,
Ma'am.
yes. Yes, you proceed. You proceed.
Okay, ma'am. A 2 months old female child of birth, born out of non-consanguineous marriage, residing in Silvatur, Dindigul, was referred from Dindigul Medical College, whose informant is mother, whose stability is good, came with chief complaints of cough and cold for 7 days and history of fast breathing for 5 days. History of cough and cold for 7 days, wet cough, insidious in onset, no diurnal or postural variation, no aggravating or relieving factors. History of fast breathing for 5 days, which is acute in onset, progressive in nature, no aggravating or relieving factors. Shall I proceed, ma'am?
Yeah, but
Yes,
I really little like I am worried about one thing. The postural variation will mostly cause some change in the cough, like if baby is lying down or sitting or sleeping. But you are saying strictly there is no diurnal or postural variation. So you want to change your statement or you stick to your statement?
And what diurnal variation do you expect in a 1-month-old child? Do you expect
If it's like on lap, it will be little different or lying down. So most of the time there's some difference mostly. So you think it is not
Okay,
right
ma'am.
and it is like exactly same, no diurnal variation and postural variation. Okay.
Okay, ma'am. History of cycle, history of forehead sweating, history of increased periodic no history of fever or skin rashes, no history of bluish discoloration of lips and mucous membrane, no history of poor weight gain, no history of irritability, no history of dependent edema, no history of reduced output, no history of abdominal distension.
Where
Doctor,
did
how
you
did
look
you
for the
elicit this
dependent?
history of,
Okay.
ma'am? So
Sir?
how did you elicit this history of
Sir?
sacrosanct cycle, doctor? Doctor, this is not acceptable for a postgraduate. Okay, what you have presented is definitely not acceptable for a pediatric postgraduate. You have to give me more details. How did you elicit a history of sacrosanct cycle? What made you tell this history of sacrosanct
So
cycle? You'll have to elaborate further for me.
So we asked mother whether the child is taking bit breast. Sir?
Yeah, tell me.
Sir, we asked whether the child is continuously feeding for 20 minutes or whether the child is taking a break in between feeding. Like that, we asked, sir.
So what did she say?
The child is taking feed for 5 minutes and the child is giving a pass and then again feeding, sir. Like that.
Why is the baby stopping after 5 minutes?
Sir, can't understand, sir.
So why did the baby stop feeding?
Sir,
If the child is having any underlying we are suspecting to have any underlying heart disease with the
Doctor,
decreased stroke volume, the child. Sir, I
no.
You should not suspect
I'm
heart
not
disease right
I'm
from
not
beginning.
going to pathophysiology at all. I am asking you only the history, okay? So we'll keep all the pathophysiology discussion for later. We are only in the history, okay? So why did the baby stop feeding after 5 minutes?
Sir. So due to effort intolerance,
So
sir.
what effort intolerance? This is history, okay? You have
Father,
to tell me what the mother told you.
mother told that the child is taking feeds for 5 minutes and again the child is getting dyspneic, so tachypneic, so that the child is getting a pass and then again the child is feeding for 5 minutes and again the child is getting a pass, sir.
Okay, I'm sure the mother did not tell this very clearly. Okay, now
We asked whether
No, mother cannot have a
whether the
stop
child is
clock, no?
continuously
5 minutes,
stop clock
5
and
minutes.
say exactly every 5 minutes the baby is stopping feeding, right?
Okay, sir.
See, doctor, this history is not important only just for passing your exam. Okay, so
Okay, sir.
once you become a pediatrician, also this history is very important. Like ma'am and I will not decide when to intervene on a VST based on what we see on echocardiogram. We are going to intervene on a VST based only on what the mother's history is. Okay, that is the main indication for intervening on a child. So supposing tomorrow you come across the same child in your clinic, this history is what is going to guide you as to when to refer the child to a cardiologist. Yes, passing the exam, but even beyond passing exam, history is extremely important in this case. So that is why we are, trying to spend so much time on it. Okay. So the way I will look, and ma'am, please provide your inputs, ma'am. So the way I will look at it is, I will ask the mother what is the baseline breathing rate, okay? Because I think you said this was a second order child, right?
Yes, sir.
So the mother already had a previous child, so she will know very well what is the normal breathing of a newborn baby, okay? So the first question is, how is the baseline breathing? It will not be normal, okay? If the baby is having sacrosanct cycle, that means that there is a size of reasonably large defect, and then the baby will have some baseline tachypnea, which as second gravida mother will be able to really appreciate and bring out that history, okay? I'm sure if you had spent time with the mother, she would herself come with that history. The second thing you'll have to, before going to sacrosanct cycle, you should ensure adequacy of breastfeed, okay? Sometimes if the mother's output is not good enough, the baby may not have sacrosanct cycle because there'll be less milk to feed, okay? Third, you have to ask the mother whether the breathing becomes faster while feeding, okay? Before the baby stops, does this breathing speed become progressively faster, okay? And then you said
Okay, sir.
rest for some time, feeds rest for some time over 20 minutes. So at the end of 20 minutes, did the baby have enough milk? So you'll have to find out whether the breast became empty. Most mothers will be able to tell you that very clearly. You have to find out how long the baby sleeps after a feed. And, because the baby might stop feeding and have inadequate feeds. He may get up again in half an hour and cry. All of that needs to come out in the history, okay? So after every feed, how
Okay.
long does the baby sleep? What is the breathing pattern during that sleep? So immediately after feeding, is it fast breathing, and then after some time does it reduce, or is it continuously fast? Okay, and how is the mother's output, and does the output reduce? Does the breast become empty? And even you'll have to ask about the number of urine, number of times the baby passes urine also. So all of this needs to come into the history. Cycle 4 is sweating, increased precordial activity, that is okay for an undergraduate. But for a postgraduate, that is definitely very inadequate, okay?
Okay, sir.
And these are questions we ask every day in our clinic. So history is the most important determinant in finding out what is the correct time of intervention for the child.
Madam,
Okay,
your
sir.
questions, ma'am.
So, Annie, I agree. The thing is about history is very special thing that you are not putting your inference, but rather what mother is telling you have to listen that, and you have to put forward that part. And also, like if you are putting 5 minute kind of numbers, so everybody will know that mother is not never knowing that it's 5 minute, 5 minute, 5 minute. So obviously, a maximum mother can know that it is 20 minute or 30 minute overall feeding time. But this breakup she cannot make. So that means you are giving that number. So you should not go to that.
And typically, every time with these large VSTs, the first time they feed, they'll be able to feed slightly longer. But then progressively it will become less only. So if you say 5 minutes, then I know that you know the diagnosis and you have cooked up the case accordingly.
Okay, sir.
So that is why you need to listen to the mother. Okay, most mothers will give you all of the history. You need to give occasional leading questions to get the history. That's all.
Okay, sir.
And again, why
And
did
I also want to know one thing, that you have put no history of fever or skin rash. Then you are
rashes?
saying no history of bluish discoloration, lips and all. You are talking about history of suck rash, suck cycle. That means you are expecting to have a underlying congenital heart disease. Why you are bringing in fever and skin
Fever
rash
and
in
skin rash.
between before the cardiac history? Then also I would like to know no history of dependent edema. How did you find, and how will you look for a dependent edema in this age group?
Ma'am, we asked whether there is any edema on lying position in the sacral region. If she noted any swelling like that, we asked, ma'am.
Doctor, how many patients have you seen sacral edema in a 1 month infant? Like I think you're final year, right? So how many patients with sacral edema have you seen in your tenure? Like,
Not seen, sir.
yeah, so it is not something very common, and it's not something which you can pick up very easily. Okay, so that is something
sir.
which even a mother will struggle to definitely find out. So I think again, that's what stop focusing on getting the right case sheet and just stick to whatever you learn from the mother. Okay, so dependent edema on the history to elicit from even a reasonably educated mother, even if the mother is a doctor, it will be very difficult to pick up. So I think you should refrain from that
So why
history.
did you bring this history of fever and skin rash up in the queue?
To rule out any infective endocarditis, ma'am.
1 month old child, infective endocarditis. So which kind of
No, sir,
infective endocarditis results in skin rashes?
as a complication, I'm ruling out the complication of
In a-
infective endocarditis, sir.
In a 1 month old with heart failure, how frequently do you see infective endocarditis?
Rather, if you say that
large
it is
EST
a
only.
myocarditis, I want to rule out, then probably I will think it over. Like you are thinking of fever, skin rashes as the underlying cause. But if you are thinking about CSD, you are thinking of endocarditis in this particular age group, and you know, sacral edema or any kind of edema, if you are thinking about congenital heart disease, so edema is not such a common finding. So,
Okay,
chalo,
ma'am.
please continue.
And one final thing, this poor weight gain. So what was the birth weight and what is the current weight? Sorry.
Sir, birth weight is 2.4 kgs, sir. Current weight is 3.7 kgs, sir.
What is
How
the
old is the
age?
baby?
2 months, ma'am.
What should be the weight now according to birth weight?
According to birth weight, the child should be 3.9 kgs, ma'am.
Or how much it is right now?
3.7, ma'am.
So did
So
you ask the mother how the weight was at different points? You know, like maybe at 15 days or 1 month or during the 45-day immunization?
Weight gain was there, sir. While immunization, she told that the child weight was around 3.2 kgs, sir.
So why is it important to make this differentiation, doctor, in a child with heart disease as to when the weight started faltering? Why is it important?
So because when the child goes in for a failure, there will be poor weight gain and failure to thrive, sir. Around 4 to 6 weeks, the pulmonary vascular resistance begins to fall, and the shunt will start to function, sir. So that there will be poor weight gain and all, sir. Because of increased demand and reduced supply, the child also
Doctor, all of that
will
is
go
fine.
for failure,
So
sir.
what I'm asking is this time frame. Why am I stressing on the time frame? Why am I asking you what is the weight at 2 weeks, 1 month, 6 weeks, like that? What is the importance of this time frame in differentiating the cause?
In case of the child has to be opted up for surgery soon, sir.
So see, I mean, the main history-wise, the important thing is, you know, if it is shunt lesion, like say a VSD or large PDA, it is unusual for this weight symptoms to start in the first month of life. So generally it starts, you know, beyond a few weeks of life. There are some more complicated heart diseases, like cyanotic heart disease with increased pulmonary blood flow. They have symptoms right from the newborn period. Okay, so say if you have a child with truncus arteriosus who presents with something very similar, their weight gain would have been poor from the first week. Whereas a simple VSD or a PDA, generally they are not very symptomatic in the first couple, at least first 2 or 3 weeks. So that is why it's important to differentiate when this weight started faltering. Okay.
Okay, sir. Shall I proceed, sir?
Smita
Okay.
ma'am, anything else, ma'am?
No, only thing is probably for them to understand subsequently that no history of Lewis discoloration whenever you are thinking about a serious heart disease, which may cause so many things, then if it is a large VSD, if it is a truncus, then during crying there will be bluish discoloration. I think it has to be there. So did you ask then while crying, is there any change in color?
Yes, ma'am. We asked ma'am, but mother said there is no change in color
It's
of the
okay.
oral
Okay.
cavity.
Okay.
Past history. History of similar comes on past. The child was taken to Delhi Medical College where I to heart disease and was given oral medication and advised to continue uh, uh, to give continuously on OPD basis. Mother discontinued medication on her own for past 1 week.
So doctor,
Ma'am,
now see, just go back one slide, please. So one more slide. See, you have said this is acute onset fast breathing, which is progressive in nature with no aggravating and relieving factors. So based on this, I thought this is my first impression is this is a respiratory infection. But now this is definitely not acute in onset, okay? This has been going on for more than a month. The child was diagnosed to have heart disease and started on medications. So I think this is not how I would personally present this case. I would have started the presenting illness from 1 month back. And, based on whatever you have said, wet cough and acute onset breathlessness, everything is more consistent with the acute respiratory infection. Whereas this history has been going on for more than a month based on what you have told me 2 slides back. Okay. So personally, how I would have presented is this: the presenting illness started 1 month back with respiratory symptoms, for which the baby was admitted, diagnosed to have a heart problem, started on medications. There was some improvement with medications, but the moment medications were discontinued, it started worsening rapidly, resulting in a second admission. Okay, this is how
Okay,
personally I
sir.
would put this case, and I think that will convey the history in a much better way than what you have tried to do.
So many time in congenital heart defect, we start right from birth, the type of birth and how was the first few hours and all those things. So that explains, because it is a very small baby. How old is he or she?
2 months, ma'am.
2 months. So only 2 months, 8 weeks. And then I really want to know that how do you correlate this cough? What is the reason for this cough in this baby? And what thing you are thinking when you are talking about the cough in this 2 months old child? So why it is there?
Ma'am, cough due to respiratory cause or any metabolic cause or a cardiac cause, ma'am.
That is what I wanted to listen from you. A cardiac cause and cough, congenital heart defect. When there is a cough, a presenting symptom in a congenital heart defect. That too
Ma'am,
in
can't
2 months
understand,
old.
ma'am.
Which congenital heart defect present with the cough in a 2 months old child, baby? Why there will be a cough? Because of underlying
Ma'am,
heart disease.
in any left to right shunt due to increased pulmonary blood flow in ASD, VSD, PDA and all, it will be presenting of, ma'am.
Uh, Actually, cough is not a significant presenting symptom of the congenital heart defect, unlike the left-sided obstructive region, unlike the LV, left ventricular failure, where you get a pulmonary edema and you have a cough. So whenever you are getting even if a known diagnosis of congenital heart defect, for whatever reason somebody underwent some echo and no, the PDA is there, RBSD is there, still if cough is happening, you have to think it towards the infection and some respiratory tract infection, upper or lower. So you have to look for that. And the other thing could cause this cough because of some irritation, because of some abnormal vascular ring or something like that. So maybe that may, but persistent cough is not known even in that. So the pulmonary edema is the main cause for the cough, and this thing is very unlikely you will see in a congenital heart defect in a smaller baby. So whenever you are getting it, you should actually investigate for the infection.
Okay, ma'am. Shall I proceed, ma'am?
Yeah, sure.
Antenatal history. Mother's age at marriage 18 years. Spontaneous conception at 22 years age. Pregnancy detected at 5 week amenorrhea, PT, confirmed by UAG at booked and immunized. First trimester, no history of vomiting, no history of fever with rash, no history of spotting PV or urinary infection, no history of drug intake or radiation exposure, dating scan done, and gestational age confirmed. Second trimester, quickening filled at the 5th month of gestation, iron and folic acid tablets not taken, first dose of Tdap given at 20 weeks, history of anemia diagnosed at second trimester for which iron sucrose injection and blood transfusion was given, no history of fever with rash or bleeding PV, no history of drug intake or radiation exposure, no history of epigastric pain or blurring of vision or pedal edema or headache. Anomaly scan taken and was normal. Third trimester, continued perceived fever movements, no history of bleeding PV, no history of pedal edema or headache or blurring of vision or epigastric pain, no history suggestive of DM or thyroid disease, growth scan taken and was normal. Total number of AN visits 9. Mother's pregnancy weight 46 kg, weight gain of 11 kgs during pregnancy 57 kg.
Go ahead.
Ma'am.
Go ahead.
Yes, ma'am. Natal history. Full term baby delivered by elective LSCS, indication previous LSCS, delivered at Typical Medical College, cried at birth, birth weight is 2.410 kg, breastfed within 1 hour of life. Postnatal history, ICU admission, exclusively passed urine and meconium within 24 hours of life, no history of bluish discoloration of skin in newborn period.
No history of bluish discoloration of skin in newborn period and subsequently, because there was no history of blue, है So you can actually make it more comprehensive. More. Okay.
So how easy is it to make out bluish discoloration of skin in the newborn period, doctor?
Sir,
how easy
by
or
seeing
difficult?
the oral cavity, you can find in the newborn period by looking at tongue while crying, by looking at lips and all, you can find the cyanosis, sir.
Actually, doctor, I mean, this is probably not related to your exam, but for you to take forward, clinical examination is notoriously difficult. It is very notoriously difficult to pick up cyanosis in a newborn. Okay, so even for somebody trained, like a neonatologist, they can actually struggle unless the saturation is say in the 50s or 60s. Okay, so that is why the most reliable way to pick up cyanosis in the newborn is only by pulse oximetry. And that is the very reason why pulse oximetry screening was brought for screening of congenital heart disease. Okay, so even an expert, even a pediatric cardiologist, cannot reliably pick up cyanosis if the saturation is more than 70% in a newborn. And there are actually very good studies which have demonstrated it. Okay, they've asked neonatologists, cardiologists to look at babies and say whether they are cyanotic or not without knowing the saturation, and they found that it is their ability to pick up is actually very poor. Okay, so unless the baby is saturating in the 60s, which means the baby would have gone into the NICU, you would have been so sick that you had gone into the NICU, it is almost impossible to pick up significant cyanosis clinically. Okay, you need to say it for your exams, but just for you to.
Priya and Niranjana, both of you can answer, ma. Whoever knows the answer can come forward and answer. Both of you can contribute. Okay. Good evening, MSV sir, and welcome, sir. Smita, ma'am.
Yes, I am listening. And this is a right point, because I didn't comment on that, because pulse oximeter, if you are using or you are not using, I am not knowing. But the thing is, sometimes cyanosis cyanosis is part of newborn period. You cannot say there was no cyanosis, but I am not saying anything. Mostly new babies born with the hemoglobin of say around 17, 18 gram%, and therefore some visible cyanosis they are not in the at least periphery, hand and feet. So when you are saying there was no cyanosis, yes, if you are very specific in telling me that cyanosis was there or not there, then you can always you should always remember that hand and feet of the babies sometimes may look cyanos, but they are not actually desaturated. That all is becoming because of the polycythemia, जो little bit is there in the newborn period. So that is also a factor. So I'm just adding up what Dr. Maniram says, and he's absolutely right that your pulse oximeter should be always there, and you should always remember that you may have some cyanosis which may not be related to anything, only because of the high hemoglobin level.
Okay, ma'am. Okay, ma'am.
Okay. So continue, please.
Yes, ma'am. Immunization history. Immunized up to age. Last vaccination at 1.5 months of age according to National Immunization Schedule. BCG papule present.
Just one thing, like,
Family.
ma'am, correct me if I'm wrong, Kritika ma'am. Like in Tamil Nadu, we give pneumococcal, right, which is not present in the national immunization schedule, correct, ma'am?
Sir.
Pneumococcal vaccine is now currently in schedule, sir. We are giving until 6 weeks, 14.
6 and 14 weeks, sir.
That is in Tamil Nadu, right? It's not in the national immunization schedule,
It's
correct?
a national immunization
Oh,
schedule.
sorry, ma'am. Sorry, ma'am.
It is national 6 weeks, 14 weeks, and at 9th month. So in Tamil Nadu, only in endemic districts, JE is being given.
Okay, okay.
Family history. Low history of heart disease in family members. History of sudden infant death. Shall I proceed, sir?
Yeah.
Yes.
Socio-economic history. Pakka house. 2 rooms with separate kitchen, 3 persons. Separate sanitary facilities available. Uses boiled corporation water for drinking. Father's education 10th standard. Mother's education 11th standard. Occupation, Asian. Monthly income 20,000. According to modified Kupuswamy scale 2025, the family belongs to lower middle class. Contact history. No history of contact with active case of tuberculosis.
So what is the relevance of this for this case, doctor?
Summary.
What is the relevance of active case of tuberculosis in a 2-month-old infant? Is there any relevance?
For completion's sake.
Completion, then probably you should ask about the viral illness in family.
Yeah, that is probably more relevant to this
Okay.
patient. And if that's an older sibling, that sibling might have had a respiratory infection from which this child could have got cough
You
and
are
cold. Okay, I think
Okay, sir.
at least for a young infant, you should be refraining from doing all this program.
Okay, sir. Summary. A 2-month-old female child, second born, out of non-consensual marriage, was at medical college as heart disease, present with history of cough and fast breathing for 7 days, with increased cardiac activity and succession, probably a case of acyanotic congenital heart disease, which features congestive cardiac failure. So I would like to proceed with CVS examination after general examination to confirm my diagnosis.
But the way I would summarize is this is a 2-month-old infant who has been having respiratory symptoms for more than 1 month, who was diagnosed to have a heart disease and started on therapy for the same, and who has now presented with an acute exacerbation of the illness. Okay, and who also has history suggestive of.
Okay, sir.
Okay, so I mean, this is not a likely case. This is a confirmed case. The child has had an echo and being told to have a heart disease. So you presented that in the history.
Okay, sir.
Okay. So this is a confirmed case of heart disease. You have the diagnosis. The mother has the diagnosis, even if you didn't get it.
Okay, sir.
Go on to the examination.
In the general examination, child is alert, awake, afebrile, tachypnic, no dysmorphic faces, no pallor, no icterus, no cyanosis, oral cavity was normal, no clubbing, no lymphadenopathy, no sacral edema, and no other external markers.
No,
What?
here cyanosis will not do. Like in history, I can accept, but here you have to give the pulse oximeter values before
Okay,
saying
ma'am.
cyanosis.
Okay, ma'am. The saturation was 98% in right upper limb and 97% in the left upper limb, and 97 in the right lower limb, and 98 in left lower limb in rheumatoid, ma'am.
Go back and continue with your history. So what we say
Okay.
in this case, there was no apparent cyanosis. No apparent cyanosis. Okay. Then you will come into the pulse
Yes, ma'am.
oximeter, then
Okay,
you
ma'am.
give exactly what is, because in the cyanotic congenital heart disease, if saturation is around 92-95%, then you don't see cyanosis. So there's no apparent cyanosis. It was fine. Okay. Clubbing in
Okay,
2
ma'am.
months. So yes, this is the question from Dr. Vishwanath.
So do you expect clubbing in a 2-month-old
ma'am.
infant, doctor?
2 months old, it's very early, sir. Usually the clubbing won't be seen in 2 months
So
old
then
child.
you, again, so that's why you get
Okay, sir.
caught, okay?
It will not commit, sir. Okay, sir.
What other external markers did you look for?
Polydactyly, syndactyly. Other facial dysmorphic facial features like suggest of Down syndrome, like involuted slant or any palm, single palm or crease. Brachycephaly.
I think instead of saying external markers,
Any
I think it's
hypertelorism,
safer
sir?
if you say there are no obvious dysmorphic features or external anomalies instead of using the word markers. Because marker means
You have said dysmorphic
Okay.
faces, then why you are using this? No other external marker. Dr. Maninam is exactly very, I mean, thoroughly he saw your presentation, and it is very true that no dysmorphic faces, then why external marker?
Shall we proceed, ma'am?
Okay. Because if you were not saying that no slant and all, na, then if you are saying so, that comes under the dysmorphic faces. I can say that, okay, if you are thinking about
Yes.
the sixth finger, then things are different. Okay, then can be external mark.
Okay, ma'am. Okay. On head-to-toe examination, the head was normal. It was open, 2 cross 2 centimeter. The spine appears normal. Limbs was normal, and genitalia was also normal. Moving on to vital signs, the pulse rate was 140 per minute, regular rhythm, no specific normal in body, no femoral delay. The respiratory rate was 70 per minute, regular, abdominothoracic. BP was 80/50 in right upper limb, 80/50 in left lower limb, 80/56 in right lower limb, and 70/56 in left lower limb. Saturation was 98%. Catheter refilling time was less than 2 seconds, and peripheral and central pulse volume was good. Temperature was 98.6 degree Fahrenheit.
What pulse characters were you looking
Shall I
for?
proceed, sir?
What pulse characters were you looking for in a 2-month-old child? The heart rate of 140 per minute.
Rhythm and volume.
Volume, you've written normal volume.
Radio
That's
father,
no, you've written no
yes,
specific character.
but
All of that is fine.
Yes, sir.
What pulse characters do you know of?
Pulse, pulses alternance in left ventricular failure, sir.
Would that be present in a 2-month-old with heart failure?
No, sir.
And somebody with a heart rate of...
Sir,
So see, in a newborn or in a small infant, it's going to be impossible for you to look at the pulse character. Okay, nobody expects you to comment on pulse character. So what I would expect from you is again the pulse radius, whether all the peripheral pulses are of good volume. That's all I'm going to expect of you. Okay, and even a radiofemoral delay will not be present in a. So either the femorals will be present or they're going to be absent. So radiofemoral delay is something which you expect in somebody who has a coarctation with the collaterals, okay? And you're not going to have collaterals in a 2-month-old child. So in a 2-month-old child, again, when you present a case in your ward, you will not be telling all of this, right? In the exam, what the examiner would expect of you is to present what you would do in any case which you present in the ward, okay? So any 2-month-old infant, when you do rounds with your chief, what will you present? You will tell them what the pulse rate is, whether all the peripheral pulses are present or not, and whether the pulse volume is good in all the peripheries. That is all you need to stick to when you present the case as well. So don't prepare something special for your case, okay? Stick to what you would do for every single patient you see during your clinic. Again, I think, again, in the respiratory rate, I would also expect you to comment on the work of breathing, okay? Somebody who has a respiratory rate of 70 per minute, I need to know whether the work of breathing is normal or not. So that should come in your vitals.
Okay, sir.
And then what is this plus and all?
So central pulse volume will be 3+ and peripheral pulse volume will be 2+.
I don't think it is a very standardized thing. So I will refrain from using all of that. I don't know if it is very standardized. To the best of my knowledge, it's not. So I think I will refrain from using these terms.
Okay, sir.
Temperature, where did you check the temperature?
Axillary temperature, sir.
In a 2-month-old?
Axillary temperature only discuss.
Did you really check, or is it something which came up while writing the case sheet?
We really checked the temperature and it was only 98.6. The child had no fever.
Okay.
Okay, go ahead.
The current weight of the child is 3.7 kg and the length was 56 centimeter. And the weight for length was between -2 and -3 standard deviation. And the head circumference was 30 centimeter. Moving on to CV examination, inspection, the wall appears not symmetrical laterally. The precordial bulge was seen. Apical impulse seen over the precordium below and lateral to the left nipple. No other visible pulsations, no other chest wall deformities, no scars, sinus or dilated veins. Subcostal and intercostal retractions were present.
So again, Dr. Scars, sinuses, dilated veins. What condition would you expect scars to be present?
Any previous surgeries?
If there's a previous surgery, shouldn't you have mentioned it in your history?
History, yes. Okay, sir.
So what conditions would result in dilated veins over the chest wall?
Any superior or inferior vena cava obstruction can result in dilated veins over the chest wall.
So how common is superior vena cava obstruction in a 2-month-old infant, and what will be the presenting symptoms of somebody who has superior vena cava obstruction in 2 months of age?
Yes, we'll take the history.
Okay. So always present only things which are relevant to your case. Okay, as a postgraduate,
Okay,
as
sir.
an undergraduate, it's okay. presenting everything which will come in a standard series
Okay, sir.
examination. But every single thing which you utter should have
Okay,
some
sir.
relevance to the patient you are examining. Okay.
Okay, sir. Shall I proceed,
Yeah.
sir?
Yes.
Palpation, sir, ma'am.
Continue, please.
Okay, ma'am. Palpation, apical impulse at the left sixth intercostal space, 1 centimeter lateral to the midclavicular line, which was hyperdynamic in nature. Systolic thrill present over the lower sternal border. There's no parasite or no palpable.
Oh, but now this is really going downhill a bit. What does that systolic thrill determine? What does the systolic thrill suggest for you?
That is the murmur is of grade 4. It will be associated with the thrill, sir.
So
That
what? How
may
do you,
suggest. Sir,
how do you grade a murmur? Systolic murmur.
6 gradings of murmur, sir. Grade 0, grade 1 is very faint, very audible in a silent room. Grade 2 is soft, which is easily audible. Grade 3 is moderate, not associated with thrill. Grade 4 is associated with the thrill. Grade 5 is easily audible with stethoscope and associated with thrill, very loud. And grade 5, even with the steth barely off the chest wall, the murmur will be audible.
So what does a higher grade murmur indicate?
High grade murmurs will indicate the opening of the means the underlying the defect will be smaller. If the defect is small, the intensity of the murmur will be high, sir. The pressure difference between the two chambers of the defect will be more.
So there is a lot of blood passing through a much smaller space, is what a higher
Yes, sir.
grade murmur indicates. So in
Yes,
a
sir.
child who was diagnosed to have a heart disease before 1 month of age, who was started on medications, which resulted in some improvement, but immediately worsened as soon as the medicines were stopped, who was not having adequate,
Yes, sir.
who's been having some plateauing of weight gain, with having gained only 200 grams since the 1.5 months vaccination. Do you expect the child to have a large defect or a small defect?
Large defect, moderate to large defect.
So would you expect a systolic thrill in somebody who has a moderate to large defect?
Less likely, sir.
Not less likely, it is impossible.
Okay, sir.
Okay. So even somebody who 2-month-old, even if he has a small VST, he will not have a thrill, okay? Because the LV pressures won't be as high to cause a thrill to be palpable, okay? So anybody who has a
Yes,
VST
sir.
at 2 months of age, it does not matter if it's small or large, it is impossible to have a thrill.
Okay, sir.
So even without seeing your patient, I know this child will not have a thrill, okay?
Okay, sir.
So why did you say that systolic thrill is there?
When we saw there was some thrill, like we felt that, that's why we commented.
Okay, go ahead. And I really want to know that what exactly is you're finding in the cardiac auscultation. Go ahead.
In the tricuspid area, a harsh blowing pan-systolic murmur of grade 4 or 6 heard over the left lower left sternal border, better heard over the third and fourth intercostal space with the diaphragm of the stethoscope.
Okay. Okay.
Mitral area, yes, sir. The mitral, pulmonary, and aortic area also had the same murmur but with reduced intensity.
Okay.
On examination of the respiratory system, it was
Yeah,
with
something else you have written.
support.
I could not listen you. You have written 4 lines. Actually, I listened only 2 lines. Mitral area S1 masked by murmur. S2 normal, same murmur is heard with the reduced intensity. Pulmonary area, S1 masked by the murmur. S2 normal,
It's
same
normal
murmur is
and
heard
same
with the
murmur is also
reduced intensity.
in
And
all
S1 masked by
areas,
murmur, S2 normal, same murmur is heard with the reduced intensity. Okay.
it's like
So what do you think, which part is involved actually from your auscultatory
the
finding and the previous finding?
since the murmur was in greater intensity in the left lower sternal border, uh, the
What
most
kind
like
of murmur it could be actually? S1 is
pan
masked by the murmur. Yes. S2 is normal.
pansystolic murmur.
Chalo, theek hai, okay, go ahead. Next
So,
slide.
so pansystolic murmur, what are the causes of pansystolic murmur?
Mitral regurgitation, sir. Tricuspid regurgitation, sir. Ventricular septal defect.
So all of these events will happen only after the S1 happens, right? So why should the S1 be masked by the murmur?
Okay, sir.
So none of these systolic events, all of them are going to begin only after the S1. So S1 will almost always not be affected by these conditions, okay?
Okay, sir.
That's what you wanted to tell, isn't it, ma'am?
Yeah, S1, actually there is a definite history of heart failure because of some underlying cause. And weight is not there and the whatever the things are there. And then it shows that if we are thinking about the shunt lesion, we are thinking about a significant shunt lesion. Then suddenly I am getting a finding S1 masked by murmur where S2 is normal. You know, if S2 is normal, S1 is masked by murmur. So severe mitral regurgitation or maybe TR, maybe you may not hear this S1 component very clearly. But then what about the S2 and how I should actually join the dot? I'm just thinking loudly. That is why I'm asking.
And again, for a postgraduate, S2 normal is completely unacceptable. Doctor. What are the components of the S2? What does the S2 indicate?
A2 and P2, sir. Closure of aortopulmonary valves.
So it's closure of the arterial valves, right? And there are two components, there's an aortic component and a pulmonary component, okay? So the most important finding for any infant with, or any child with heart disease, most of the diagnosis is based on, not on the murmurs, but on the S2. So for a postgraduate saying S2 is normal is completely unacceptable. So you'll have to tell me about the two components, okay? Whether you are hearing two components or only one component, whether the IoT component is louder than the pulmonary component or not, okay? And whether the split is normal, wide, all of that you need to tell me. So S2 normal is not acceptable for a pediatric postgraduate. So it has to be whether the S2 is split or not, and whether the IoT component is louder or the pulmonary component is louder.
And
Okay,
a
sir.
pansystolic murmur because of TR, if you, I think, I mean, a distant possibility that softer S1 is because of the TR, because its murmur is coming at the lower sternal border. Then in that case, you will also get a this pulsatile lever. So that is also a finding you expect. Chal, come. Yeah.
Respiratory system examination, mean causal and retraction, but RNG was present and there was no added sounds.
Okay.
On examination of abdomen, there was
You didn't get any crepitation in the lungs?
No, ma'am.
No. And you are saying the cough is because of the congenital heart defect. So cough is mostly because of the alveolar edema, no? So it is not there, but you are not getting anything. Okay. Okay, go ahead.
Abdomen examination, the liver was palpable 1 centimeter below the right costal margin, soft in consistency, and span was 5.5 centimeter. The spleen was not palpable.
And it was not pulsatile. Please tell at it was pulsatile or non-pulsatile, because you have given finding, which may be TR also.
Okay, ma'am. Okay, ma'am. The spleen was not palpable and there was no distension and no free fluid.
Yeah, doctor, a liver which is only 1 centimeter and soft in consistency in a 2-month-old child is essentially no abdomegaly.
Normal.
Right.
That is also normal. Exactly. I missed that point.
Somebody who has such florid heart failure and admitted twice with the respiratory symptoms within 2 months of age, and who discontinued diuresis, and that resulted in the subsequent worsening. I would have expected at least a 2 or 3 centimeter liver, which would have been at least slightly firm by 2 months of age. So did you examine this child a few days after admission, or was this at admission? And did the child receive any decongestion during the admission before you examine the child?
We examined after 2 days of admission, sir.
So did the
The
baby
child
receive
was
any?
on antibiotics.
Okay. So then I think you should bring that also into your history, okay? Because your findings don't match with what I expect to see in this child. So I was carrying a picture of a child who has significant heart failure. And now, based on whatever you have told me, it doesn't look like a significant heart disease at all. Like from whatever you have presented so far to me, this child probably has some respiratory infection because he has tachypnea, subcostal and intercostal retractions, and he does not have a hemodynamically important heart disease because his S2 is completely normal according to you. There's a very harsh pansystolic murmur. So nothing is fitting from what you say. So I think you should bring that in the history. You should bring that the child has been admitted, treated, and there is some improvement in symptoms subsequent to initiation of treatment. Okay.
Okay, sir. CNS examination, the tone was normal. The diagnosis was a case of acyanotic congenital heart disease, left to right shift, most probably moderate to large VSD in sinus rhythm with congestive cardiac failure with no pulmonary hypertension.
So what are the features?
Pulmonary hypertension.
Yes, no pulmonary hypertension.
Large VSD and no pulmonary hypertension.
A large VSD will always have pulmonary hypertension. There's no possibility of no pulmonary hypertension in a large VSD. Now you have to tell us what are the findings in your clinical examination which support your diagnosis. So you made a diagnosis based on your clinical examination. Tell us what are the findings in the clinical examination which supports your diagnosis.
The child had no cyanosis, and the child had a pan-systolic murmur in the lower left sternal border, which would also suggest a VSD. And the child had symptoms of suppressed cycle, forehead sweating, which would suggest cardiac failure in the child.
There's no palpable P2 and no audible P2, sir. So there is no hypertension, sir.
So that's what you. No, you have not answered my question. What are the findings in your clinical examination which support your diagnosis?
So the saturation was normal, so we are ruling out any congenital heart defects. There is no central cyanosis or peripheral cyanosis, sir. Then on auscultation, we heard
your diagnosis that
systolic
it's
murmur.
acyanotic. We have accepted this thing that this baby is acyanotic. So we are not talking about.
We are not challenging that.
No, we are not talking that. You have to actually justify your shunt lesion. That's it.
Why do you say this is a large VSD?
Since there was a poor weight gain and in examination, actually it was.
Can start from inspection palpation. Huh?
Yeah, start from inspection palpation.
So there was a clue there, right? Can
On
start.
inspection, the child had on inspection, the child had a precordial bulge, sir, which will be there in the moderate to large VSD.
No,
And
no, no.
the
Precordial
In a
bulge.
2-month-old precordial bulge?
2-month-old, no.
No.
No, not at all, because we always say that the onset of CHF in VSD is usually 8 weeks and so. So that means to establish a cardiac dilatation fully, it will take some time and then affect the thoracic cage. So it cannot happen at 8 weeks.
Thank you. The apical impulse was
shifted laterally, so it suggests there was cardiac enlargement. It
So
would
there
be
are-
seen in large VSD.
Okay, fine, accepted. Yeah, then.
But the murmur was on grade 4, sir.
Okay, auscultation wise, what will be the features you expect in a large VSD, and what are the features you'll expect in a small VSD?
in large VSD, there will be pansystolic murmur with a flow murmur
So-
across the.
Auscultation,
Sir?
does it start with the heart sounds or does it start with murmur?
The S2 will be, there will be wide variable split in S2, sir.
Wide variable split. In which condition? Small VSD or large VSD?
In large, sir, in small left to right shunt lesion with no hypertension, there will be wide split S2, sir. P2 will be of normal intensity, sir. Whereas in the large left to right shunt, there will be pulmonary arterial hypertension.
What
So
do
there
you
will
mean
be
by wide and variable split?
A2 normally aortic valve closes prior to the pulmonary valve. But in this condition, because of the left to right shunt, there will be delayed closure of the pulmonary valve that will result in wide splitting of the S2 aortic pulmonary valve.
So in a 2-month-old with a respiratory rate of 70 per minute and heart rate of 150 per minute, how easy or difficult is it going to be for you to make out a wide but variable split?
It would be difficult, sir.
And you told me that in a small VSD you expect a wide and variable split. And then you tell me it is because of increased pulmonary blood flow that the P2 gets delayed. If it is a small VSD, the pulmonary blood flow will not be significantly increased, right?
Only in large VSD.
So that's what you need to understand, certain hemodynamic principles. That is what ma'am is also trying to say. Okay. So whenever you have a small VSD, the left to right shunt is not going to be very much. Okay. So the pulmonary pressures will be low. So what you would expect is a completely normal X1, a normal split of the second heart sound, and a reasonably harsh pansystolic murmur. You will never get a thrill, even if it's a small VSD in a 2-month-old. Okay. Because for a thrill to be there should be a very significant difference between the LV pressure and the RV pressure. The LV pressure will not be so high in a 2-month-old. Okay, even in a normal 2-month-old, the LV systolic pressure may be around 70 millimeters of mercury. Okay, so you will never get a thrill in a small VSD at 2 months of age. Whereas in a large VSD, what is the problem? There's a very large hole and there's a lot of blood going from the LV to the pulmonary artery. So the pressure in the LV and the RV will be the same. So you will always have severe pulmonary hypertension in infant or in anyone with a large VSD, small baby with a large VSD. Okay. So the S2, the pulmonary component will always be loud, okay? And the murmur will be soft. But more importantly, all of this blood which goes from the LV to the pulmonary artery, how does it come back? Where does it go back?
Left atrium.
So it goes back to the left atrium and the left ventricle. So you'll have a increased flow across the mitral valve. So what are the features of increased flow across the mitral valve?
With diastolic murmur across the flow murmur will be there. With diastolic murmur across the mitral wall.
So you'll have a S3.
Systolic murmur. Yes, ma'am.
So you'll have a S3 and a mid-diastolic murmur at the apex. Okay. So these are the features which help you differentiate a large VSD from a small VSD clinically. Small VSD, you don't expect tachypnea. Small VSD, you won't expect cardiomegaly as based on a shift of the apical impulse. Small VSD, you don't expect a large liver. Small VSD, you expect a completely normal split of the second heart sound with a soft pulmonary component, and you expect a much harsher murmur. Okay.
Okay, sir.
So based on the points which I said, there is nothing from your history except cardiomegaly and fast breathing to suggest a moderate to large VSD. Correct or not?
Yes, sir.
So
Priya
what has happened
Niranjana,
is,
Priya Niranjana, it looks like you have studied well. Don't get panic, and you just try to list out all the positive findings. You have done everything well. Okay, cool, be cool, chill, and list out all the positive findings. Okay,
Okay.
Okay, ma'am.
sir, please, sir. Sir,
yeah,
yes, sir, please, sir.
yeah. So go on. Next, what investigations do you want to do first?
You
Oh,
can
well,
sometimes tell that as to I was not able to hear because the heart rate was very high and as well as the respiratory rate was very high, so I could not quantify. So those acceptance
Okay.
is taken with good sense, because if you are being honest, then you are being honest. So then you are leaving this thing open that it may be wide variable, it may be something else, but because of the present situation, you are not able to get it.
Okay, ma'am.
whatever ma'am says is very valid. Okay. So because I mean, it's much better to say I don't know than try to find findings which fit your diagnosis. So that is where you will get into trouble.
Okay, sir.
I think it's already 9:15, so we'll skip all these routine investigations, go to cardiac specific for want of time. So what is the first investigation you want to do cardiac wise?
Chest
Chest
X-ray,
X-ray, sir.
Good. So what do you expect to see in this child?
cardiomegaly, and
What else?
Increased
pulmonary
pulmonary
plethora.
Okay, fine. So
Do you have
can you,
X-ray and ECG? So show that. Wow.
so how do you define pulmonary plethora, doctor? I mean, it may not be perfectly relevant for a 2-month-old, but still, how do you define increased pulmonary blood flow?
Increased bronchovascular markings, which is even lateralized, involving even the lateral one-third also. Sir.
Extending up to periphery, sir.
Okay, so that's actually, I mean, that's correct. But what is more relevant is, I mean, it's not extending up to peripheries, yes, but something which is much more relevant is increased size of the end-on vessels, which you see on the X-ray. So it's very difficult to point out the end-on vessels in the particular X-ray. I think you should have probably taken a zoomed-in picture. But I don't know if can you point out any of the end-on vessels, Dr. Priya?
So I can like I think there is increased bronchovascular marking because up to lateral third I can see some bronchovascular marking, but there is infiltrates also. So there's something else underlying. It is not isolated cardiomegaly or something, this thing. I think lung infiltrates are there definitely. So respiratory component could be there. I cannot see these playing up the left bronchus because it is a very underexposed and not a very good quality of. But it is very interesting because why I'm saying the infiltrates are there. If you look at the base at the right dome of diaphragm, you can see that the part of lung is hyperinflated lung is actually covering this spine midline. It is covering like kind of herniating or something like that. So the lower lobe is hyperinflated compared to middle zone and the upper zone. So there is some compensation is going on with the respiratory this thing. And I think these lungs are not very good in this X-ray, and I cannot comment on the shunt lesion as if now. Or I think liver is not 1 centimeter; it is more than that.
Definitely more than that.
Because at least it may not be span, because it may be a kind of push down because of this lung inflation. You can see that part of lung blackish shadow coming on the spine. Can you see that?
Yes, yes, ma'am.
So that is a lung which is getting hyperinflated. Yeah.
You can use the pointer, ma. Yeah, you can use the pointer and trace it.
Okay. So next ECG.
We
No,
couldn't,
ma'am.
we couldn't take ECG, ma'am.
Fine, that's fine.
Okay.
So what do you expect to see on the ECG in a large VST chapter?
Right axis deviation, sir. Due
Not,
to
not necessarily,
There will,
but what is much more important?
there will be biventricular hypertrophy features.
Very, very good. What will be the feature of biventricular hypertrophy?
in mid precordial leads, there will be tall R and deep S waves, sir.
So just for your exams, what is the name you give for this?
Katz-Waxtel phenomenon.
Katz-Waxtel phenomenon, sir.
Good. Okay. Next, what investigation do you want to do?
Echoes.
Echocardiography, sir.
Okay. So in the echocardiography, like, so can you pull up the echo report?
Sir,
Echo report.
What did you see first, echo report or patient?
first we saw echo report and initially before history taking.
You knew
That
the
is-
diagnosis, huh?
So that is the problem with most of the things which happened during this. Okay, so you started with the echo report and then went and saw the patient. And unlike most of the specialties in pediatrics, in cardiology, every single thing is connected to what you see in the patient. Okay, so
Okay,
like a large VST, the timing of intervention is not based on what you see in the echo. It is based on what we see in the patient. Okay, so whether there is heart failure clinically and on history, weight gain, feeding, all of that is what is going to decide your timing of intervention. Okay,
Yes, continue, Dr.
So this is something which all of us do every day in our clinic. So we don't straight away jump into doing an echocardiogram, even if a child who's known case of VST comes to us for review. So you need to focus on all of this history. So again, what happened was you guys knew this was VST. You went and read about VST in your book, and then you went to take the history, and you tried to fit everything into what you read. Okay? So never do that. So as long as you get your clinical examination correct, even if you don't get the correct diagnosis, or even if you don't answer most of the questions, you'll still pass as long as the history and examination makes sense.
So I really wanted to add only one thing, because I was once upon a time for the cardiology chapter. I created workshop in 2010 and 11, and those were the hands-on echocardiography workshop. And now today I am standing here and never saying that echo workshop has to be done. And I prefer to go for a clinics, because I understand that unless you understand the hemodynamics, the your clinics well, X-ray well, ECG well, even a echo is there, you will not make a right diagnosis. 100% I am telling you. And there you are not there to make right diagnosis and the intervention. This is for the pediatric cardiology and the whatever cardiac setup are there. So your first preference should be that you identify a patient on right time, get a right diagnosis from right place, and then you refer on the right time. So this is what it is. So for that, you need to know your clinics very well, and you should not think about the echo unless you know your clinics very well.
Okay, ma'am.
So what do you want to do with this child now, doctor?
What was the diagnosis actually on echo?
So moderate to large VSD was there, ma'am.
So what do you want to do with this child, doctor?
Sir, we started on medication with anti-failure drugs, sir, diuretics, furosemide.
So what is the dose of furosemide you will use?
1 to 4 mg per kg per dose per day, sir. Per day we will divide it in TDS or QID dose, sir.
So generally, the standard dose of furosemide in any infant is
1
1 mg
mg
per
per
kg
kg
per
per day,
dose,
6 mg per
BD or TDS. Okay. So 4 mg per kg per day is a very high dose. We don't. So generally, it is 1 mg per kg per dose BD. What is the main side effect of? What are the major side effects of furosemide?
So I would like to add,
Hyperkalemia.
because if you're saying that it's a really, if I agree with you that systolic murmur was as good as you told me, I will never give the diuretic even twice a day, because this only will hamper the weight gain further, and it will irritate child quite a lot, and electrolyte imbalance. So you should know that diuretics are very, very kind of special drugs. They should not be mindless. You should be very mindful when you are using them, and you must know there are some after effect other than the removing the extra body fluid. So one has to be very careful, and you should actually go and see what exactly is the diagnosis. No start for any drug unless you know what is the diagnosis.
Okay, ma'am.
And generally, like as a practical point, whenever you are giving diuretics more than once daily, furosemide more than once daily, you should always start it along with the spironolactone, okay?
Okay, sir.
Because otherwise you'll end up with hyperkalemia and problems related to hyperkalemia. So whenever any patient is on more than once daily of furosemide, they need to be on some kind of potassium sparing.
Okay, sir.
So what next
let-
you will do, mother, like tomorrow, what you are going to do? You are going to see this patient thoroughly. What Dr. Mangnam said, whatever I made the contribution, but please go, revise your diagnosis, take a senior person, okay,
Okay,
and
ma'am.
then only you go and see the X-ray. You get a better picture of X-ray. This picture is not saying everything, because if I see this picture and your CRP was quite high, so I am right also, because this patient is having lung infection right now.
Okay,
It was
ma'am.
49 if I correctly, I didn't see wrong.
Yes, ma'am.
Let's put aside all the inconsistencies in the findings. Let us assume this is an infant with a very large VSD. When will you refer this child for a definitive intervention? Okay. So, as ma'am pointed out, there are some discrepancies which makes us doubt the diagnosis of large VST. But let's put all of that aside. Let's just assume this is a very large VST. When will you send this child for definitive intervention, a surgical intervention?
Child, if the QP/QS ratio is more than or equal, if it is more than 2:1, then that is an indication for surgery. If the child is having large VSD, as you said, sir, associated, surely there will be pulmonary hypertension. If there is pulmonary hypertension, even if the symptoms are controlled with the medical management, then the child should be referred to surgery.
So when will you send this child? When will you send it for?
6 to 12 months.
So, doctor, 2 admissions, 6 months is not acceptable at all. Okay. So with 2 admissions and a large VSD, you need to send this child for surgery as soon as possible. Okay. So if there's one thing which I want you to take back from today, it is this: there is no age for surgery for a large shunt lesion. Okay. If there is uncontrolled heart failure, which seems to be the case in your child, this child needs to be operated as soon as possible. There is no age criteria and there is no weight criteria for an intervention in a large shunt lesion in an infant with heart failure. Okay.
Okay, sir.
Can I just have a comment?
Yeah.
Yes, sir. Yes, sir, please.
Thank you. I think good case presentation. Thank you. Wonderful discussion, Dr. Manidam and Dr. Smita Mishra. I just want to ask you, I think as the faculty have mentioned, it's very important that the clinical, the case examination should be very strong, especially when you're moving into this AA world. It's very important. My only thing is, when you're saying about CRP 59, I just also want, as Dr. Smita rightly mentioned out, I would like to also know, is there any element of sepsis, blood culture, anything, because when we say something, then we have to add a bit more information. That's the only thing I'm asking. This child is a cardiac case, but when we say something about CRP, and then there is I just want to know whether any sepsis in this patient, any blood culture taken. I just any additional information, just I want to know. Thank you.
Blood culture was taken, sir, and it was no growth only, sir, for the child.
Okay, thank you.
What was your radiologist comment or your comment or Dr. Kritika on the X-ray? Actually, what was your interpretation?
Ma'am, actually, it is a rotated film, ma'am, and underexposed film, and there is definitely a cardiomegaly. And as you told, there is an hyperinflation over the right lower zone of the lung, ma'am. And I feel there is an
increased at that area.
Increased bronchovascular markings, ma'am. Increased bronchovascular markings were there. So I would vote for cardiomegaly and pulmonary plethora.
And the other thing is, I just want to ask you, can the high CRP be just explained only based on the large VSD? Or I know that the blood culture is negative. Would you do a viral respiratory viral panel, given the fact that some of the viruses like adenovirus can have a high CRP,
Yes.
given the fact that it's blood culture? Just asking a question.
Yes, sir. We can have that, sir. In adenovirus, we can have a high CRP and also increased neutrophil counts can be there, sir. So
Okay.
probably the child is having a viral illness.
Thank
The
you.
hyperinflation with the bilateral hyperinflation, it's probably a viral pneumonia more than a bacterial pneumonia.
Thanks.
So one thing you should know that when you call it pansystolic murmur and loud enough, that means in a case of shunt lesion, that means not even in any lesion which is causing a loud murmur creating a thrill also. That means between two chamber where blood is flowing, the pressure gradient is quite high. So if it is a LV and it's RV, if pressure in the LV is say 100, so your RV pressure is approximately 35 for 40, not more than that. Then only a loud murmur will be generated. And similarly for the TR or MR, because RV will generate at least 25 in presence of normal PA pressure. So RA pressure are quite high, 0 to quite low, 0 to 5. So that's why you get a loud murmur. So here, if I am saying that it's a VSD and a loud murmur, then I am saying that PA pressure are hardly 40. And if I am saying PA pressure are hardly 40, then I cannot explain this X-ray based on VSD and plethora. So that is what my concluding
Yes.
remarks on
Yes,
this.
ma'am. Yes, ma'am. Yes, ma'am. Priya, do you have the echo reports with you, ma'am?
No, ma'am.
Oh.
Currently, I don't have.
Okay.
Thank you so
Ma'am,
much, but it was
ma'am,
well presented. I am very happy the girls tried to do whatever they tried to answer every question. And this is the time for learning, so they can make mistake and we are there to correct that.
ma'am, your concluding remarks, ma'am.
So this is my concluding
Okay,
remarks
ma'am.
that we should know that hemodynamics is something like more engineering, less medical. So the numbers we never should add. We should be very honest. What we see as a scientist, as a person, as a medical person, whatever we see, we should not try to cook it more than what it is. So that is very, very important thing. And even with the examiner, if you are not getting some finding and you are telling honestly that this finding, this thing I cannot understand, then people will actually explain you. They are not going to fail you.
Thank you, ma'am. Thank you so much, ma'am. Maniram, sir, your concluding remarks, please, sir.
Again, I think what I already told you, okay? So a cardiac case, I think it's based, 90% of it is based on a history and maybe 10% on examination, okay? So, and you need to present only things which you will look for in your daily clinical examination. So you won't be looking for clubbing in a 2-month-old. So why do you want to put it in your case sheet? You won't be looking at pulse character. So why do you want to put it in your case sheet? So focus on your history and go with an open mind, okay? Don't go with a fixed diagnosis in your mind. And I mean, unlike respiratory, the respiratory and other things, 1 + 1 does not always mean 2 in a respiratory case, but in a cardiac case, 1 + 1 is always 2, okay? All the findings which you see will be consistent with what the final diagnosis will be. So go with the open mind, give a lot of importance to the history, try to get, and most mothers will be able to give you history. You just need to give occasional leading questions to get them in the right direction. And focus on what findings you see in your daily rounds. So don't treat your exam case as different from what you see as a daily rounds case. Okay.
In simple words,
Okay, sir.
In simple words, we have to push the boundaries of your performer and you have to go beyond. You shouldn't be sticking to the performer. Rajkumar sir, are you here? Sir, your concluding remarks. Rajkumar sir, can we have you, sir? Rajkumar sir?
Just one more point, ma'am. This is not
Yes,
just
sir.
about your examination, okay? The same principles apply even when you see a patient as a consultant or as a registrar or as a senior resident or whatever you work as. So this is something which you need to carry beyond your examination as well.
Well taken, sir. Point well taken. Priya and Niranjana, do you want to say anything?
We'll improve, ma'am. Thank you, ma'am.
Yeah, you did
Thank
well.
you.
You did well. You have examined the case. The one thing is you have got tensed a bit, right? So this is what happens in all the exams. So the examiners are here to calibrate and fine tune you. Okay.
Okay.
Sir, any remarks from Vishwanathan sir? Thiru sir? Thiru sir?
I think we
Singaravellu
are.
sir? Thiru sir?
Yeah. Thank you very much, everyone, for. I'll start with Dr. Rajkumar and Dr. Nandini ma'am for organizing this program, for getting their pages to present this case. As everybody very often thinks, okay, VSD is a simple VSD, but it's not. And we are really thankful to Dr. Smita Mishra and Dr. Ma'am and Dr. Ramaniram for a very wonderful discussion. And of course for the postgraduates for trying their level best. Probably they got sucked with the fact that they knew the diagnosis and then just was trying to steer the whole case. If they had been a bit more open-minded, I think it would have been a lot more pleasant for them. I know, but even otherwise, I think they still made a very good attempt, which is very important. And I especially thank Dr. Rajkumar for helping us to bring everybody together, and Dr. Kritika for the last 12 months for being a very sincere person in organizing the program. I know it's not easy. To be very honest, this was one of those programs where I did not mind much because I knew things will get done. There are other programs where I have to put my heart and soul into it to make sure it goes on, but not in this one. So thank you very much, Dr. Kritika. And
Thank you for the opportunity,
I hope that this program continues for some more time. It should be like one of those long-lasting programs, because it's not easy to have 125 episodes of a program over a 5-year period. So I'm sure we should be able to continue it next year as well. So thank you very much, and I really enjoyed, and I hope that the students and the PGs and even UG students join us, who joined us, and maybe those who are on the YouTube would learn more from this very wonderful case discussion. I mean, again, once again, thanks to Dr. Mishra ma'am and Dr. Maniram. Thank you very much, and hope to meet you again next year. Thank you.
Thank you so much, sir. So my sincere thanks to Rajendran sir, Narmada ma'am, Singaravelu sir, Rajkumar sir, Thiru sir for trusting me and having granted the opportunity to me. Thank you, sir. And I can see Smita ma'am still in the conference, and Maniram sir is still in his scrubs. So in spite of your busy schedules, thank you so much for accepting our invitation and guiding our students, ma'am and sir. It was thoroughly enjoying, and I learned so many points from you both. Thanks again, ma'am and sir. And thank you everybody for being here till the time. And Priya and Niranjana, thank you so much. And Nandini ma'am, Rajkumar sir, thank you so much for accepting our invite. Sir, shall we close the discussion? If there is
Yeah, I think we can probably overshot.
Ma'am,
Thank you very much. Good night.
thank you, ma'am. Good night, ma'am.
Right.
Thank you. Good night, ma'am.
Thank you, ma'am. We really
Nice.
enjoyed the discussion,
Yes,
ma'am.
yes,
Thank
yes,
you.
yes,
Thank you.
yes.
Really nice
thoroughly
experience
enjoyed.
for me. Thank you so much.
Thank you.
Thank you.
Thank you.
Thank
Good
you.
night.
Thank you, Maniram sir.